Next up, delighted to welcome Orna from Nanoscent Labs, who'll be talking about the breath research and COVID work that they've been doing. Orna is research director at Nanoscent, where projects include developing and studying artificial olfactory systems based on nanocomposite materials in conjunction with pattern recognition algorithms for detecting cancer via volatile compounds, as well as planning and managing clinical trials. She previously worked as a researcher and teaching assistant at Technion, Israel Institute of Technology, and as a research assistant at the Marie Curie Excellence Center for Artificial Olfactory Systems. Orna has a PhD from the Laboratory for Nanomaterial-Based Devices, Department of Chemical Engineering, Technion, Israel Institute of Technology. Welcome, Orna, and thanks for your time.
Hi, everybody. My name is Orna Barash. I'm going to present you outcomes and conclusions from a clinical performance we did using our VOCIT system for the detection of COVID-19 from exhaled breath. I would also like to take this presentation and to present the idea of breath collection standardization and to get your feedback about it. I will go over the presentation. Thank you for inviting me. It's a great honor. I would like to start with a few words about Nanoscent. It was established in 2017 with the goal of making scent readable through the analysis of breath VOCs so that people can make wiser health decisions. Nanoscent is located in the northern region of Israel, where a talented multidisciplinary team of more than 30 people from various professionals like organic chemistry, biology, data scientists, software development and material engineering work together toward the goal of making breath readable. So about Nanoscent technology, first our goal is to make Scent platform to enable the platform to perform easy, non-invasive and user-friendly testing. Our system is based on providing a breath sample into a bag, which is then inserted into the VOCIT. This is the VOCIT system. You can see it here. The VOCIT then analyzes the sample and provides results in less than a minute. Nanoscent core technology is based on proprietary chem resistors, which are composed of a conductive core and an absorption layer. Nanoscent is specialized in designing the nanocomposites as well as in methodologies to deposit them on the desired substrate. Each sensor, here you can see a picture of one sensor, is composed of 12 different what we call sensing elements, and each element can be tuned to show high sensitivity to different VOCs based on the application and research in question. Each sensor's resistivity is recorded and compared to its resistivity when it's exposed to the volatile organic compounds. The multiple change derived from the sensor array is actually the VOC fingerprint or the volatile fingerprint. So to enable a quick and safe breath collection, we also designed a special breath collection bag. You can see here in the picture from the news and also here. The bag, we call it air trap, and you can see it here, as I said. During the design process, we selected the bag material which provided the least amount of background VOCs and the minimum VOC loss when filled with breath. Moreover, we wanted to choose the bag to have the minimum response when it filled with nitrogen, compared to bag filled with breath. From this process, we created the air trap breath collection bags. Nanoscent's technology can basically be tuned to send diverse types of VOCs, ranging from alcohols to alkanes, ketones, and aldehydes, and thus has the potential to be customized for detecting various diseases. During the pandemic, we have decided to dedicate our technology for the detection of COVID-19 from breath, and our goal is to launch this as our first product to the market soon. So apparently we weren't the only ones who thought to study VOCs in COVID-19. During the last 18 months, few studies have been published, all emphasizing the possibility of identifying COVID from human secretion, mainly breath and saliva. Most of the studies used either some kind of spectroscopy like GCMS or IMS, or used dogs for this purpose. Though these studies have their limitations, the outcome of the studies definitely increased our confidence that COVID does have unique breath pattern that can be detected from the breath. When assessing the common VOCs between the studies, it seems that aldehydes show the greatest potential, and this is why we have decided to focus our technological development efforts toward the detection of aldehydes in human breath. So just over a year or so ago, when COVID was at the beginning, we were there with a very promising, though premature technology. At the time, we decided to quickly test our sensors for the purpose of seeing whether they could be tuned, work for the detection of COVID-19. So we went for it like cowboys. We were at all drive stations in the north and center of Israel, as well as at Sheba Hospital, collecting breath samples from people suspected of having COVID-19 disease. We also got IRB approval from the IDF, the Israeli Defense Forces, to collect samples from soldiers at the recovery facility. So in total, breath samples were collected at 7 different locations, both indoors and outdoors. Samples were collected at the hospital environment, at the corona wards, and at the ER. We also collected samples outside of Israel, in the UK and UEA. We collected samples very early on of the disease when this was still in chaos and many things were unknown on the international level, like how to define the disease, how to identify the spreaders of the disease, and what is the exact role of the asymptomatic carriers. I think some of those questions are still in vague and are still not very clear. Anyway, after analyzing more than 3,000 samples, we got some really amazing results of more than 85% accuracy, which is an average of sensitivity and specificity depending on when you put your cutoff. However, when we took a deep looking into the data, we noticed a huge influence from factors, variation between samples, location, date of sample collection, and the device used to analyze the samples. We understood we have a great potential here, but that something needs to be changed, that we need to come to this problem of breath collection analysis with a much more organized approach. Actually, this was also the main feedback we got from the regulation, both the European and the American, the FDA. So while the FDA showed a great interest, they were also confused and not very clear regarding the required performance for the approval. Due to many applications they got in breath collection, each presenting different approach of sample collection, analysis, and reporting, it was unclear what was the best method. Again, a great problem due to lack of a standardized approach. I put here a quote from one of the town hall meetings. You can see it online. And they said that in order for us to authorize a brand new technology like this, at least in the beginning, until we get and demonstrate that it performs as well as more classical tests. So it's very clear this is a new technology. This is something they don't know. Many companies are approaching FDA with different approaches, different methods for collecting and for analysis, and it's confusing. Beyond that, the main feedback we got from the FDA led us again to the understanding that we must be very focused. We need to understand what are the VOCs. We need to understand their mechanism. It was also very important for the FDA to understand what is the mechanism, the physiological role of the VOCs in the disease. When we do that, they believe, and also we believe, a higher sensitivity and specificity will follow. Immediately following the feedback from the FDA, we took a second trial, take 2 I call it, and we started a VOC study in Spain. In this study, actually, we didn't use our devices. It's just a GCMS study to mitigate or to validate actually that aldehydes are indeed our target VOCs. It makes sense from a biological perspective. We wanted to see that they are detectable also using our method for sample collection. So for this purpose, we collected breath samples in 2 different methods. One method is that Alston developed, We bought the Houston services for that matter, and we compare it to our breast collection methodology, which includes air collection into a bag, then absorb it on tube, and analyze it in our laboratories. So we just finished the whole sample collection, and we're now analyzing the samples in two different laboratories, in Nanocent laboratories and Houston medical laboratories, and results will be published hopefully soon. So in order to reduce sample variability and to increase our confidence in the results, we identified 4 main components that we must carefully consider when performing breath analysis. The first is related to sample collection or preparation. We ask ourselves, do we need to use any means of sample preparation to make them more coherent and reducible? Do we need to perform any sensor calibration or to apply a baseline? And if we do, what kind of a baseline? Then we consider the environmental factors. Temperature and humidity are huge concerns when working with chem resistors. Thus, it's important to eliminate any variation in temperature and humidity using both mechanical and physical elements and software or algorithmic methods. The third component in standardizing breath collection is related to breath fraction. In order to reduce the inter- and intra-participant variability in the samples, it is crucial to develop a clear methodology for breath collection. Each methodology should be easy to follow both by young and adult population groups, as well as by those who might be sick and have difficulties in performing the breath collection test. Moreover, it's important to understand the source of the target VOCs and accordingly plan the sample fraction required. Last but not least is related to reporting. In order to have the ability to share new knowledge and insight with the community and also to absorb knowledge from the community, it is super important to have a consistent and coherent reporting methodology. It's important to plan and to execute meaningful studies with strong statistical evidence and with comparable methodologies. These are basically the 4 pillars or the 4 elements which are crucial for a standardization of breath collection reporting. Here you can see a few examples for each one of the factors or the elements. For examples, you can see that from a sample collection perspective, there are many different methods used for sample collection, either using pre-concentration methods like SPME and 10x tubes, or a collection into different containers like bags or BioVoc. Environmental factors, the 2 main factors which are only also mentioned before are age and temperature, as well as different VOCs. That you expect to see different VOCs when you are at the hospital environment or when you are at the school environment, for example. With regards to breath fraction, it's also a challenge to choose the best fraction that will give you the most significant VOCs with the highest concentration, and as I mentioned before, the element of reporting. I think that the next phase would be to join forces and knowledge and build together a standardized methodology for breath collection and reporting. We need to make breath collection and analysis simple and equal, even when we use different methodology for interpreting the data. Look at the common practice of urine collection. When a person collects urine, it is very clear what he needs to do. Also, when the doctor reads the results, he can easily understand and interpret them into medical action. Our goal is to do the same for breath. Here I put some suggestions or thoughts. What are the exact things we need to account when doing either a clinical trial or trying to validate our technology, all related to sample collection and preparation, environmental factors, sample fraction, and the reporting or the additional data required. Nanocent's first focus was on breath collection optimization and elimination of environmental factor. In this slide, actually, you can see how we approach challenge of high humidity. So humidity in breath is higher by 6 to 7 order of magnitude than the VOC concentrations. While VOCs are at the ppb level, humidity is 100%. Thus, it is crucial to reduce RH both mechanically and by calibration. Nanoscent was able to integrate a unique filter to remove water vapor while keeping VOCs. This alone leads to a reduction in humidity down by several ppm. Combined with our proprietary algorithm, the sensor signals are repeatable and significant even in the presence of 100% humidity. You can see in the graph how the same sensor, you can see here 1, 2, 3, 4 different sensors, each one represented by a different color, how it responds to VOC on the left graph, and how it responds to humidity on the right graph. It is clear that while a humidity or H2O has no dynamics, there is an immediate response and then it is flat. The response to the VOC is much higher and also has a unique pattern. Moreover, the sensor response to the VOC, as I mentioned, is 4 times higher than its response to humidity. So these are only a few of our attempts to deal or to eliminate the effect of a different humidity. Of course, we do the same to temperature and to other environmental factors. That's it more or less. So just to summarize my talk, in parallel to technology improvements, which is our main goal and focus, Nanoscent is aiming to create or to join a professional association related to breath collection and reporting standardization. Meanwhile, we're open to share our knowledge with regards to study planning, sample methodologies, and so on. And I invite you all to share. I think that by sharing, we will be more knowledgeable, and we'll go together with a unified approach to the FDA. It will be much easier for everyone, even though technology can be very different. And that's it. Thank you very much.
Thank you for that presentation, Orna. That was fantastic. So we've got a good few questions coming through. So the first one from Robert. How do you consider the possibility of high false positive rates in the breath test, as aldehydes have been related to more generic oxidative stress signals related to other biological perturbations and respiratory disease, for instance? Have you tested the method not only during the COVID peaks, but also during lows with other control populations?
Yes, so Robert, it's a great question that actually we also, of course, had in mind. When we first went for a clinical trial here in Israel, there weren't much cases of other respiratory diseases, so we couldn't really evaluate the specificity of the technology of aldehydes to detect COVID. So we first decided to focus on the sensitivity and increasing sensitivity and dealing with the environmental conditions. And as a next step, this is something we're planning to do in the very near future. We will test the specificity, the ability to differentiate, not only to detect COVID, but also to say whether the person has COVID or other respiratory infection. But it's also important to keep in mind that the technology we are developing is meant for screening and for telling people they are healthy. So maybe the differentiation between COVID and other respiratory diseases is not, could be less with high accuracy rates. This is something we're still examining, but this is just to keep in mind the purpose, the intended use of the device, which is more to tell people they're healthy. Like the negative predictive value is more significant when we're talking about screening. But we will test the specificity and the concern you raised during our next study.
Yeah, and I think there's a question that was brought up yesterday related to that. So, do you actually need the specificity to COVID, or are you basically trying to say, if you're healthy and if you have any type of infection, you probably shouldn't be coming into work, or wherever the case may be? And I was interested in the slide where you got the feedback from the regulator from the FDA, where they were talking about trying to show equivalence or similar clinical performance to things like PCR, for instance.
Yes.
But again, if the use case is slightly different, be interested in your perspective there. in terms of what the regulators are saying?
Yeah, it's very tricky, because the regulation knows PCR and maybe antigen, and they mainly refer to I think that from many clinicians we've been talking, they all are interested in high sensitivity. They want to see that people are sick, and of course, if you want to place it at the point of care, they also want to know what they have, and they are less familiar with the concept of screening. And also, we felt this also from the regulation, from the feedback we got from the FDA. It seems as they want you to be exactly like PCR. And they don't really acknowledge the fact that you cost much less, that the time to result is very quick, that people can do it on a daily basis. It seems like there is still a gap there. And this is why it's a bit tricky yet.
Yeah. And obviously things like lateral flow tests have a different performance compared to PCR. So I suppose the use case also needs to be considered. The next question is from Scott. What's the lifespan and effective aging of the electrodes?
So we're actually, when we started the company, we thought we will have a like device standing for years. And now we are moving towards more of a disposable chip and replaceable chip. So you have the device, which is you buy it one time and you can replace the chip. How many times you can use the chip really depends on the sample that you expose and the environment that you stay in. For now, we define like 3 days of usage for the chip, which is corresponding to hundreds of samples.
Got it, thanks. The next question is from Thorsten. There's a couple related to this relates to the backgrounds. So the type of air inhaled was absolutely uncontrolled, indoor and outdoor. Why does the inhaled air not play an important role for diagnosis, as we'd seen in the previous presentation?
I totally agree with you. It does affect, as Morad explained. And this was one of our main conclusions from the clinical study we've performed. We learned how the inhaled air and how the environment can affect our sensors response much more than the breath itself. And this is why we went for another study with Alston also. And this is why we are performing now another study. We learned from this, and now we are implementing our conclusions, which are mainly how to exclude the environmental and the inhaled air effects. But indeed, it affects.
Yeah, got it, thanks. Next question is from Yuri. In what way was the safety of breath analysis from COVID patients achieved?
Yes, so this was actually going back to the previous question also, one of the main conclusions from the clinical study or even goals was to learn how to work in this kind of environment, in which each person is considered contagious. So we used different sterilization methods, like the regular one, like alcohol wipes and disposable materials and gloves. And regarding the breath collection, since we are not collecting a forced expired breath, but regular breath, then we expect to see less of a viral material. Also, the breath is collected into a special air trap or bag that we designed that the air doesn't leave the bag. Once it's captured inside, there is a special sleeve that keeps the air locked inside. So this was another safety mechanism. And after the breath is exposed to the device, then we put an additional filter to capture any materials or viral materials, if any.
Got it, thank you. I think we have time just for one more. Do you really know what the compounds sensor reacts to in the first COVID experiment? Are you sure it's aldehydes? Did you check the sensor response? And then the other related part there is, did you take care to do the sampling in different background driving facilities or hospitals? Did you evaluate how long your sample can be in the bag without hampering the signal or interfering with the signal?
Okay, so regarding the first question, how do we know it's aldehyde? So we didn't. During the first experiment, we just took our generic sensors and tested them in a clinical setting. We assumed these are aldehydes based on literature that was later published. And now we went for a big study in Spain together with the Austin Medical to ratify that aldehydes do correspond with the COVID. So this is regarding the first question. Regarding the second and the environmental background, as I mentioned before, we during the analysis of the samples, we noticed a lot of background effects. So it helped us better define the use of the device, where it should be placed and how to keep the environmental stable. We also invested many efforts in stabilizing the temperature and the humidity inside the sensor chamber, because we noticed that it affects very much the signal. And regarding the bag, we just initially instructed the nurses in the field to immediately expose the bag to the sensors and not to keep it inside the bag.
Got it. Thank you. Thanks so much for that. There's a few more questions. So, Orna, if you're able to do typed responses, that would be fantastic. But thanks again so much
We'll do that.
for the presentation.
Thank you.